Welcome everyone to another Diabetes Canada webinar, part of our fall webinar series. I'm very excited for you to be joining us today for weight-inclusive care strategies to manage patients with elevated weight without bias. I'm very excited to be joined by Dr. Sean Wharton today, who's going to present on the topic. Dr. Wharton has his doctorate in pharmacy and medicine at the University of Toronto. He is the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He's an adjunct professor at McMaster University in Hamilton and York University in Toronto. He also has academic staff at Women's College Hospital and clinical staff, the Hamilton Health Sciences. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes, and he's the co-lead author of the Canadian Obesity Guidelines. Dr. Wharton is involved in activism to achieve health equity in Canada. He founded the BMSA, Black Medical Students Association at the University of Toronto in 2000, and the BMSA is now a recognized mentorship organization across Canada. Without further ado, Dr. Wharton, take it away.
Thank you very much for that wonderful introduction. Yes, we're going to be talking today about weight-inclusive care, the strategies to manage patients with elevated weight without bias. So this talk is about bias and equity, and we're going to get right into it. So here are my disclosures, and there's no honorarium for this talk and no conflicts. So the objective: to identify strategies to manage patients with elevated weight without bias, stigma, and discrimination. So first of all, a little bit about me on the personal side. I'm an internal medicine doctor, as was stated. This picture of my wife, who's a family doctor in Toronto, and baby James, who is 2 years old now. So it's with the thought of baby James, I do a lot of the equity work that I do. I want this world to be a better place for him to grow up and to live. There's definitely some disadvantages being Black in the world. And certainly we'll be talking about people living with obesity, and we have the disadvantages and discriminations there. I want this world to be a better place. So so with that, for my field of research and study is in obesity medicine, but it also connects over into equity. So we wrote the Canadian Obesity Guidelines with the focus on science, but our real goal was to focus on bias, stigma, and discrimination that plagues this field of people living with obesity. So once we address the bias, we can actually then focus on the science to attain the real wins within this medical field. So now, so when we talk about these biases, we know that obesity bias and stigma, and I'll explain what both of these are, hamper the field. So we can't really go very far until we deal with this. So question is who has bias? The people listening right now, who has bias? Well, pretty much all of you do. Everybody has obesity bias. Obesity bias is a negative thing. So how can I be so sure that all the people listening right now have obesity bias? It's a pretty bold statement, isn't it? Well, here are some of the reasons. Studies show that obesity bias starts in preschool. If you show preschoolers pictures of a child living with obesity versus a child with a disability, the preschooler will never choose the child with elevated weight as a playmate. They start to address negative attributes to those with obesity, including laziness, a lack of intellect, and other harmful traits. Well, this bias continues well past preschool. We were those kids. We watched the cartoons of the thin dog and the bigger dog, and the thin dog was bright and competent and etc. So we got those biases stuck in our brain, and we become adults and we become healthcare providers. So we are now the ones with bias who are treating people living with obesity. So here's a great example of bias and discrimination from a family doctor in Canada, from Sudbury, none the less, which is my hometown. So here's what she writes in the Medical Post. She writes that losing weight is too hard because the general attitude of patients coming into her clinic is one of non-accountability. Not that there's a biological or genetic reason for elevated weight, but mainly blaming and shaming them, stating that they're not accountable. She also goes on to state that when she inquires about their diet, they're incensed when she tells them that pierogies are not a good choice. She suggests that we should just paint billboards with simple common sense information to help these patients. This is a clear example of bias leading to discrimination. And this is from a doctor who felt strong enough to write it in the Medical Post. Medical Post has since apologized for this, but certainly it is here. So what does she represent? 5% of doctors, 10%, or 50%, maybe even more. But these biases are definitely here. They're not underground. So clearly the biggest challenge facing obesity is the lack of knowledge within the medical field regarding the science and the biology of obesity. This ignorance leads to recommendations such as eat less and exercise more as the only recommendation. This simplistic message does not address the biology of obesity, and as a result, it does not work as a treatment. So the science and the real driver behind understanding obesity medicine is understanding that it is a neuroscience field, greater than 140 genetic foci, primarily in the brain, hypothalamus, the mesolimbic system, the frontal lobe. The intensity of these genetics is what drives elevated weight and what drives people to not be able to keep weight off when they actually lose weight. And these genes, as stated, lie within the hypothalamus, the mesolimbic system, and within the frontal lobe. Understanding these genes and understanding this biology leads us to treatment options. Rooting ourselves in bias and stigma gets us nowhere close to treating this medical condition. So the treatments, of course, are primarily, not, and I shouldn't say of course, but because this is not known for many doctors and healthcare providers, the main treatments are psychological intervention, or CBT, understanding the psychology there, and that's the frontal lobe, pharmacotherapy, or medications, and bariatric surgery. These three interventions support the healthy eating, or the medical nutrition therapy, and the physical activity, which are, of course, the roots of how we can treat this medical condition. Of course, anyone can do a diet, anyone can be physically active at times, but maintaining those things are oftentimes impossible unless we go to understanding the biological principles. Again, our biases push us against our understanding of the biology. So now that we've talked about bias, let's talk about weight stigma. What is stigma? So stigma is essentially a stereotype. And the weight stigmas, what they do is they reinforce our already set biases. So most people are on a computer right at this very moment. So if you stop this presentation or pause it, or just go onto the computer and type in, let's say you want to do a presentation and you want to pull up a picture of somebody living with obesity. You would, and he wants to be a man. Type in the word man and obesity and images on your own computer and tell me what images end up coming up. Of course, there are images of people with their shirts not fitting properly, their bellies showing as if they don't know how to dress and they're not competent. So these are on your computer that are showing this significant stereotype. So your immediate thing is that this person doesn't look like they could be a professional, or a doctor, an engineer, a lawyer, or a prime minister. No, they are all negative stereotypes, negative pictures, which then informs our biases and leads us to discrimination. Instead of those type of images, we should have these positive images. In the Obesity Canada Image Bank, there's positive images of people living with obesity who are moving, who are smiling, who are positive. So we also know that on top of the external biases that we have against people living with obesity, there's also internalized bias. So, and that's because people living with obesity hear all the same messages and see the same stigmatizing pictures as of themselves, and feel that they don't deserve care. Besides the external bias that we see from healthcare providers towards people living with obesity, there's also internalized bias, which means that people living with obesity hear all the same messages and see the same stigmatizing pictures and believe the same things that all of society does, that they themselves have a character flaw and don't deserve care. Research has shown strong associations between internalized weight bias and mental health outcomes, avoidance of exercise, and binge eating. So the primary solution here is for us to be compassionate and as patient as we can with our patients living with obesity, as they will, by having that compassion, they will be able to deal with their internalized weight bias against themselves and can be eventually treated. And so here are the 5 A's of obesity management. The 5 A's is something we set out in the Canadian Obesity Guidelines. And essentially, it's a roadmap as to how patients can be appropriately treated. And the roadmap looks relatively similar to all medical conditions, such as high blood pressure, diabetes. Let's look at number 2 to number 5 first. You're going to assess the patient. You're going to advise them on what treatments. You're going to agree on what goals they should be looking at or what values. And then you're going to assist them and with the follow-up. The one difference is the number one thing that we need to do with patients living with obesity, and that's ask them permission to discuss weight. And that seems a little odd, right? If you had a heart attack and you're sitting in front of a cardiologist, does the cardiologist say to you, can we discuss your heart attack and treating your heart condition? Well, it seems obvious. You're sitting in front of a cardiologist. Why would they have to ask? Well, you know what? They probably should ask. That shows compassion. And here they definitely should ask. Why? Because we've treated people living with obesity so poorly for so long that they don't trust us. And by asking them permission to engage in a discussion about weight management, which now has appropriate treatment options, that's showing a compassionate treatment. So here again, it's when we're asking for permission. This is step number 1. And we're stating things such as, would it be all right if we discussed your weight? We know that obesity is a chronic disease. The way we treated people in the past doesn't work. Would you be interested in addressing your weight at this time? So this shows compassion. We need to be better at doing this. So, and then if we move into things such as our assessments. So how should we assess people living with obesity? We frequently use things like BMI or waist circumference. I'll have a discussion about BMI. And we could use things like the EOS staging tool. So let's talk a little bit, let's look deeper at what type of assessment is appropriate and does not show bias. Well, the Edmonton Obesity Staging System says, let's not just always look at the patient's BMI or their elevated weight. Let's look at their comorbidities. Do they have prediabetes? Do they have diabetes? Do they have a family history of these conditions? If they do, and if their adiposity is driving this, then they need treatment. If they don't have adiposity that is driving it, adiposity is weight, then we're in a position where we don't need to aggressively treat it. We need to have a greater understanding that patients can be healthy with elevated weight. And if they are, then what they need is understanding and compassion and treatment like anyone else would, to not go up and up and up further in weight, to not go into a disease state, but they may not need treatment to go down in weight. And so here again, we have more of the understanding of advising the patient for management, agreeing on values, and not just, and this is again a part of the biases. Our biases have always been to tell a patient where their weight should be. And we should no longer do that. We should instead talk about the patient's values. You value being healthy for your grandchildren. Let's work on what type of treatments can get us to that type of value proposition. Assist in drivers, and also making sure that we assess the patient on an ongoing basis. So here again are the 3 pillars: psychological intervention, pharmacological therapy, and bariatric surgery, that all support healthy eating and activity. So let's talk a little bit about this BMI. We've been seeing a lot of information, and an article just came out in the National Post talking about the fact that we need to scrap BMI and that it is a flawed measure. So what do we exactly mean by this is a flawed measure? So BMI is a calculation, and essentially it's a number. As a number, it's not necessarily flawed, because I would be saying things like weight or height is flawed. It's our interpretation of it that is the challenge, or the categories. So we can see here, these are the categories that have been established to assess health status. Once you get into the overweight category, your health is supposed to not be as good. Obesity class 1, 2, and 3, health gets even worse and worse. But that is the debate here. Does somebody with does an individual with a BMI of 32, are they actually more unhealthy than a person with a BMI of 27? If that's not the case, then where did these categorizations end up coming from? And so, and this may be, so as we know, this is a case for criticism here that we may need to get rid of it. So initially, the BMI came from Adolf Quetelet. He's a physicist credited with the idea that weight increases with height squared. Quetelet was from Belgium. He came up with this in 1850. He was trying to determine the health status of the average man. Of course, the average man for Quetelet was a white European male in Belgium. And this is where the idea of using this Quetelet index ended up coming from. What happened was in 1972, Ansel Keys, a noted physiologist in America, decided to use that Quetelet index to and change it, not necessarily change the name, but use the name BMI, body mass index, was created to again determine health statuses. Again, the same categories were used, but the Ansel Keys did not take into account the varied nature of individuals. For instance, different bodies, different risk. And so we know that African American women carry most of their weight in their hips and in their thighs. They don't carry it in their central area. And as a result of that, what happens is that they're not as at high a risk of having type 2 diabetes and metabolic conditions until their BMI is significantly elevated, as to where their waist circumference is also elevated. So different bodies, different risk. The BMI's cutoffs were not for women. They were not for women of color. And they, as a result, can infer some discriminatory practices. And so the Edmonton obesity staging system, again, what this study looked at was, instead of looking at BMI, could we look at whether you had type 2 diabetes, a family history of it, pre-diabetes? Would that predict your mortality better? And clearly it did. You can see here that this is the NHANES data. And it is a database that looks at mortality. And here we can look at the EO staging system. From 0 means that you have no risk, and stage 3 means you have lots of risk. But everybody in this category, if you look at the panel on the right, you can see that regardless of what category you were, that you were actually in BMI category, what determined your greatest amount of risk was what your EOS staging system is. The highest staging you were at, the higher risk you had, not your BMI. So, and here, this is the classic one here. Everyone in this category is obese in the obesity class 3 stage. They all have BMIs of greater than 40. Everyone assumes that they should all have high risk. But as you can see, if you had a BMI of 42 and no comorbidities, that's the black line, your risk of mortality was very low. You had one comorbidity, the red line, your risk of mortality was again very low. Once you start having more comorbidities, your risk goes up and up. And so it's the comorbidities that determine the risk, not just the elevated weight or the person's size. So again, BMI may not predict health in most cases. So let's look at the patient in front of us. And why this is a challenge is because many people are denied knee surgery denied intravenous in vitro fertilization based on their weight. If we were to look closer at what causes the mortality and morbidity in these conditions, in these procedures, getting a knee surgery done or having IVF, it is more so the medical conditions as opposed to the person's weight. So, and finally, what we're going to look at here is anti-Black racism within medicine and obesity. So we'll do a little bit on this. So we know that the drivers of obesity are primarily one of the big drivers is socioeconomics and also race. So what does this mean? What do we mean by this? When we know that there's all the other drivers of biology that I spoke about, food consumption, individual activity, but look at that one spot that has societal influences there. There's one arrow. That's socioeconomic and race, and it definitely factors in. So due to this driver, we see that obesity disproportionately affects marginalized people, the Indigenous, Black people, and the poor. So I'm going to focus the next few slides on Black people within the U.S. as it is a research interest of mine, and also we have data on this to show how this discrimination or socioeconomic status leads to higher rates. So American collected race-based data to account for their slaves. That is history. This accounting continued beyond slavery and it found its way into health and into health-based data and has been helpful to document disparities within care. Canada does not collect race-based data, and this is a significant problem as it makes it difficult for us to address problems that we know is challenging here within Canada. So here are the stats on obesity by race within America. Overall, obesity rates in America are staggering, but it is clear that Black Americans are affected more than white Americans are. There is a 50% obesity BMI greater than 30 in Black Americans and 42% within white Americans. And here, if you look at Black women, they're at 57% obesity rate, BMI greater than 30 versus white women at 40%. That's almost a 50% higher rate. This disparity in rates of obesity and disparity in health was not by chance. It was by design, and it started in slavery. And it lives on today when we look at structural racism. So my friend Jamie Ard, an intern from North Carolina, has written a great paper on the topic of obesity and structural racism. He and I are one of the few Black physicians working within the field, and I encourage you to read this article. To understand the origins of these disparities, we need to go back to the days of slavery. Let's look at the slave rations. The objective of the slave owner was to help keep his investment working with the bare minimum investment in food and provisions. This often led to diets heavy in carbs, salt, excess calories from poor nutrition foods that could be burned off during the working day. Other food was obtained by what the slaves could grow or catch, but disease and poor hygienic conditions led to multiple deficiencies and diseases. The medical field was not concerned with assisting and improving health, but instead with experimentation. Here, Dr. J. Marion Sims, a male gynecologist, did experimental gynecology operations on slaves without consent or anesthesia. He did this while perfecting a surgical cure for vesiculovaginal fistulas. One woman, and her name is Anaracha, required 30 procedures before a satisfactory result, and this is challenging. Physicians attributed disease to Black people, stating that those that were peculiar to their nature, such as the quest for freedom. Physicians ignored the basic science of medicine, and that the poor conditions were leading to true medical conditions. Post-Civil War conditions were even worse. Poor nutrition and sanitation, structured and designed to weaken Black people. Healthy, free Black people were seen as a threat to social order. The thought is that Black people would die out due to poor nutrition and poor constitution. Today's food options for Black people are derived from days of slavery, high starch, fat, sodium, cholesterol, and high caloric content. Inexpensive and often low quality nature of the ingredients such as salted pork and cornmeal. The collision of food insecurity in this case is, and in this case, it's the inability to acquire, consume an adequate diet quality, collided with biology, poverty, and structural racism leads to a troubling aspect of obesity in Black women within the United States. We need to remember that Black women preferentially put energy into peripheral stores, but up to a BMI of about 32. And after that, the energy goes to fat stores in the visceral areas, leading to metabolic diseases. So although most of our data is from the US, I personally collected and conducted research, race-based data. We looked at the results of weight management at a community-based clinic in over 9,000 patients. We found that overall, women of color lost less weight than white women did. And when we adjusted for the number of visits to the clinic, there was no difference. So the issue was access to care. We could not easily reach women of color, or they could not reach us, or take time off work in the middle of the day, or find the resources for healthy eating options. The system was not built for them, but for those with privilege. We've been working on solutions to correct this by starting to do virtual care, and virtual care is, we would like to keep doing virtual care to reach these marginalized communities. So what are the solutions to the disparity in care and within medicine? There's no single solution that can undo hundreds of years of racism, and solutions will need to come from wide ranges of places, organizations, and individuals. So I founded the Black Medical Student Association 22 years ago at the University of Toronto, and it's grown every year. I believe that a new group of physicians will make a difference by recognizing structural racism in medicine and addressing these factors. They've already made significant strides. You can follow them on Twitter, on Facebook, and as a matter of fact, just today, CMAJ article was released from the BMSA. So they'll also educate non-racialized doctors and medical associations to recognize issues of structural racism and treat patients in an appropriate fashion. So in conclusion, obesity rates are much higher in marginalized groups, particularly women of color. And also we see here that healthcare providers have bias against people living with obesity. And we should recognize this bias and practice compassionate care. BMI may not be the best measure to assess health for most of the world and may perpetuate discrimination. Instead, we should look at the individual. And finally, structural racism is causative in continuing to perpetuate the conditions that fuel obesity within Black women. So thank you very much for your time. This is my academic team and my clinical team who significantly assist me to get all of this work done. Thank you for your time, and I hope that this will spur on a lot of healthy discussion. Thank you.
Thank you so much, Dr. Wharton. What a wonderful presentation. We would love for folks to give us some feedback on today's webinar. You can scan the QR code in front of you and fill out a brief survey. And we very much appreciate your feedback, comments, concerns, questions, etc. If you enjoyed today's presentation, consider donating to Diabetes Canada, www.diabetes.ca/donate. We are a registered charity which relies on support from donors like you. Your gift will help us fund all areas of our work, including making sure we can keep making webinars like this one. If you want more up-to-date information on diabetes, consider becoming a professional member at www.diabetes.ca/membership. You get access to the Canadian Journal of Diabetes, a discount to our professional conference, and access to an online community of peers, and much, much more. Consider becoming a professional member today. Members are invited to join us at community.diabetes.ca to discuss today's webinar further. Thank you so much for watching. More webinars and podcasts are available at www.diabetes.ca/healthcare providers. Thank you so much for joining us. And thank you, Dr. Wharton, for a wonderful presentation. Dr. Wharton, that was fantastic. Thank you so much. I think a really useful, informative presentation. And thank you for joining us today.
Thank you. It's really great to be here.
All right. Thank you very much, everyone, and have a great day.